and the next session, I would like to introduce Dr. Rapat, who she's extraordinary endoscopist. Chulalongkorn University is a gastroenterologist who interested in upper GI diagnosis and therapeutic. She's an expert, one of the experts of endoscopy in Thailand. Please, she will be a moderator in this upper GI session. Please, Dr.
Good morning, everyone. It is my great honor to be the moderator in the upper GI session this morning. Today, we have the great opportunity to listen the lecture from our NBIIG member who is an expert in upper GI. Let me introduce Professor Daisuke Kikuchi. Professor Daisuke Kikuchi, he graduated from Juntendo University Clinical GI Fellow at the Department of Gastroenterology and Endoscopy, Toranomon Hospital. He also received the PhD from Juntendo University, and right now he is the Chief of Department of Gastroenterology and Endoscopy, Toranomon Hospital, Japan. Please welcome Professor Daisuke Kikuchi for our morning session about the basic principle of NBI. Please, Professor Kikuchi.
Thank you very much for your kind invitation and the kind introduction for me. It's my great honor to be here, not here. I want to go actually in Bangkok. Next time I want to go Bangkok, and please communicate face to face next time. Okay. Anyway, I will start my presentation. Okay, I will. Can you see my slides?
Yes.
Yes. And can you hear me?
Yes.
Yes. Okay, I will start my presentation. And thank you again for your kind invitation and introduction. I'm Daisuke Kikuchi from Toranomon Hospital, located in Tokyo. My hospital location is very close from Professor Saito's hospital, maybe about 5 to 10 minutes from my hospital to National Cancer Center. And Dr.Supakij sometimes come to Japan, and he stay at our hospital and the National Cancer Center. And this is a picture of 2017 ANBIIG workshop held in Bangkok. And it was a great opportunity for me and a good experience. And it was so impressive for me because all of the participants studied hard. At that time, I have confidence that the endoscopic skill of Thailand doctor must be developing soon. And this time, I'm very, very looking forward to participate in this workshop. And as I told you, Professor Supakij and his team came to our hospital to see our endoscopic examination last year. And maybe he was very surprised because our endoscopic room was not so beautiful and quite old. In this endoscopic room, each endoscopic bed is located very close, and sometimes the patient can communicate each other and encourage each other, especially during the colonoscopy. After endoscopic examination, we drink together. It's my great memory. Next month, we move to next building, a new building. The location of new building is next to old building. New hospital is quite clean and has 19th floor. Yeah, this is a new building. This location is just next to Embassy of United States, very center of the Tokyo. This is the endoscopic room. Endoscopic room is located at the 4th floor, and there are 12 endoscopic rooms in our center. Yeah, it is maybe one of the biggest center in Tokyo or in Japan. And Dr. Oil, maybe he is a participant in this Congress. He is a young colleague of Professor Supakij. Dr. Oil stayed at our hospital about 4 months, for 1 month, August 2019. And sometimes we did ESD, ESD training using Pochi model. And Dr. Oil could resect the lesion in embryonic fashion without any complications such as perforation and, of course, no bleeding. We were waiting for Thailand doctor and Professor Supakij, but unfortunately, COVID-19 pandemic happened, and it is impossible. Next, but near future, please come to Japan and please stay in our hospital. Everybody in our hospital, welcome to you. Anyway, let's start my presentation. This is a classification proposed by Professor Tajiri and Professor Niwa. Professor Tajiri is a former president of our society. According to this classification, in addition to conventional white light endoscopy, there are some endoscopic technology, such as image-enhanced endoscopy, magnifying endoscopy, and microscopic endoscopy, and tomographic endoscopy. And in image-enhanced endoscopy, chromoendoscopy, such as indigo carmine or Lugol, and NBI were included. This is a representative image of IEE, image-enhanced endoscopy. Only white light endoscopy, we cannot detect the lesion easily. Can you find the lesion in this endoscopic image? If you have experience, slightly reddish area can be detected at the posterior wall of the esophagus, but some doctor can not detect the lesion easily. But if you spray iodine staining, the lesion can be recognized as iodine unstained area like this. It is much easier to detect the lesion by chromoendoscopy. As I told you, chromoendoscopy is one of the image-enhanced endoscopy. But the spraying iodine staining is time-consuming, and it is sometimes irritable for patient. And sometimes we experience a patient with allergic reaction or allergic history of Lugol. NBI is much easier. If you push the NBI button, the lesion can be recognized as brownish area, like this. Compared to white light endoscopy, by NBI, you can detect the lesion easier. And after NBI, if you can use magnifying function, you can observe the microvasculature structure like this. And observation of a microvascular pattern is useful for characterization of the lesion. And we can make diagnosis this lesion as a superficial squamous cell carcinoma with high confidence. First of all, we have to consider why is the apple red. Natural light is consisted of 3 primary colors such as red, green, and blue, RGB. And the natural color hits an apple. The blue and green light are absorbed by the apple, and only the red light is reflected back to our eye. And we can recognize the apple as red. When you apply the light without red, the apple loses its reflected light and color turned black. Next, please consider why the blood red. Hemoglobin in the blood absorbed green and blue light and reflect only red light. So we can recognize the blood as red. In white light endoscopy, RGB, red, green, and blue light a broadband light, like natural light, illuminate. And such long wavelength light can penetrate to deeper layer of the mucosa. But if you push the NBI button, the NBI filter is inserted between xenon lamp and RGB filter. In NBI endoscopy, 2 nanoband lights such as blue and green illuminate. Blue light is 415 nanometer and green light is 540 nanometer, respectively. Nanoband image illuminate 2 specific short wavelength light. Therefore, it represents superficial microstructure and microvascular pattern of the epithelium very well. Can you understand my Thailand language? So when we illuminate the white light to the mucosa, blue light scattered and reflected in the superficial layer, but red light reach to deeper layer and then reflect. In NBI, only blue and green light illuminate. Furthermore, blue and green light is absorbed by hemoglobin well, so it represents superficial microvessel well in its image. Green light and blue light is 415 and 514 nanometer, respectively. This is a representative case. I will show you 3 cases. Can you find the lesion? In all of them, there is a lesion, very small, and very small lesion in each image. Can you find the lesion? It's a little bit difficult, but if you push the NBI button, it is much more easy to detect the lesion, because the lesion can be recognized as brownish area. In each image, such a small brownish area can be recognized. And compared to white light imaging, NBI can be recognized as brownish area for such small lesion. Characterization of the lesion can be possible. First lesion, you can find the microstructure like intestine, and you can make diagnosis. This small reddish area is ectopic gastric mucosa. So it is not necessary to take biopsy for such lesion. And next case, you can recognize such dilated vessel, and vascular density is quite high. But each dilated vessel has no character of caliber change and very straight. And if you can find such lesion, you should make diagnosis this region as angioectasia. And it is not necessary to take biopsy for such lesion. Final case, you can maybe detect such dilated IPCL. If you find such lesion, this lesion is squamous cell carcinoma, and it is necessary to resect by EMR or ESD technique. So if you use NBI, you can detect small brownish area very easily. And if you can use magnification, you can characterize the region like this. It is the power of the NBI and the NBI magnification. And how to use the NBI is important. First of all, we have to know the ideal setting of white light imaging and NBI. And you can change the contrast enhancement level from 0 to 8. And please check the setting of the endoscopy before the endoscopic examination, not only NBI, but also white light imaging. In white light imaging, you can change the contrast enhancement from A0 to A8. The endoscopic image of A0 is blurry, not so clear. Compared to A0 mode, A8 mode is much sharper. I recommend to use contrast enhancement mode A8 or A7 in white light imaging. Please check before the endoscopic examination. In NBI, same as white light imaging, there are settings from A0 to A8. This slide shows the image of A1 and B1 mode. This image is not so clear. If you change the mode A8 or B8, this is the representative case of A8 and B8 mode. This slide shows the difference type A and type B enhancement. Compared to type A mode, type B mode microvasculature structure can be recognized sharper. So ANBIIG group recommended B8 mode in upper GI endoscopy. Yeah, the demarcation line can be recognized very easily, and in the region, we can detect the microvasculature structure. The microvascular is quite irregular, and the microstructure is also irregular, and we can make diagnosis such region as gastric cancer with high confidence. And please use B8 mode in the upper GI endoscopy. And in NBI, there are 3 color modes, 1, 2, 3. Compared to color mode 1, color mode 3 is more green. Color mode 2 is halfway between 1 and 3. In upper GI endoscopy, we recommend color mode 1. However, lower GI endoscopy, color mode 3 is recommended. Maybe Professor Saito will present this setting. In the technical aspect, the food is essential for NBI magnification. Food is useful to keep the adequate distance from the target region. Before endoscopic observation, please check the length of the food. I think this is the ideal situation of the black food. Black food should be attached 2 mm from the tip of the endoscope. Please check the situation by yourself in each time. The tip of the food is slightly visible at the upper part of the endoscopic field during non-magnification observation. And when you use low magnification, the tip of the cap is not visible. The black food does not obstructive for visual field during the non-magnification observation because of the coloration. And this black food is quite soft, so the mucosal injury does not happen. This is a technical point of NBI magnification. Lesion, especially cancer, is sometimes fragile. So if you find some suspicious lesion, don't observe from the distal portion first. You should observe the proximal portion first. And you should attach the tip of the cap at the edge of the lesion and deflate the air slowly and slowly and slowly. So lesion itself comes to the lens, and perpendicular observation is possible. And when you find some suspicious lesion, can you find the lesion in this endoscopic image? If you find such slightly depressed area, please take endoscopic image from the distance and close to the target lesion, little by little, little by little. Because if you take only this image, it is difficult to explain the location of the lesion. And in NBI, please do in same way. Please take endoscopic image from the distance. New NBI is so bright and it is easy to detect the lesion from the distance, like this. And after taking a non-magnification image, please do magnification. If you do not use black food, it is difficult to observe the lesion perpendicularly. However, if you use the black food, it is possible to and easy to observe from the adequate distance. And the microvascular pattern can be recognized very easily. And you can make diagnosis this lesion as cancer with high confidence using NBI magnification. In summary, I was talking the principal NBI. Using the NBI filter, only green and blue light illuminate the target lesion. Blue and green light scatters and reflect in the superficial layer. NBI use only two specific wavelengths light and represent superficial microvessel and microstructure very well. And next, I was talking the setting of endoscopy. In white light endoscopy, I recommend the A8 mode. And in NBI, ANBIIG group recommend D8 mode in contrast enhancement, and the color mode 1 is also recommended. But I recommend please check every endoscopic before every endoscopic examination, the setting of the endoscope. It is very important. And finally, I was talking the technical point of NBI magnification. Black soft food is very essential for magnifying observation. Black food is helpful to keep adequate distance to the target lesion. And vertical observation is possible using black food. And during the NBI magnification, the amount of the air is also important. Please deflate the air slowly and slowly. So lesion is coming to the lens and the beautiful magnification image can be obtained. Thank you very much for your kind attention. Thank you.
Thank you very much, Professor Kikuchi, about your crystal clear lecture for the principal basic of NBI. Right now, no question from the audience, but however, I would like to ask you about your recommendation about the black hood or a diagnostic NBI. What do you think about the plastic or the clear hood for using instead of the black hood? We can use it instead of the black hood?
Yeah, for NBI magnification, I recommend black hood. And the length of the black hood is very important. I recommend 2 millimeters from the tip of the endoscope. Because if you use the transparent hood, the transparent hood is a little bit hard compared to the black hood, and sometimes bleeding happen. And bleeding is very obstructive for NBI magnification, and I recommend black hood in NBI magnification.
Okay.
Thank you very much, Professor Kikuchi. May I ask you a question?
Thank you.
So would you recommend using the black hood in every time that we do the upper endoscopy? Would you recommend?
Yes, I will recommend for NBI magnification, but I don't recommend for screening endoscopy. So if you know, if the patient is referred to your hospital and you know there is a lesion, I recommend to use the black hood. But for screening endoscopy, I don't recommend.
Okay, understood. And then to your experience, how many times that we can reuse the black hood before it burn out? This is important question for our country.
Yes. I'm not sure, but black hood is very tough, and maybe I think it's my opinion. It's my just personal opinion, but maybe over 100 or 200 times you can use.
That's so good. Thank you very much.
Okay. One question from the audience. What is the difference between A mode and B mode that you recommend for using?
Yeah, ANBIIG recommend B8 mode. Yeah, there are two modes, A and B. And A mode enhancement is A mode is for structure and vessel. And B mode is contrast for the vessel. And if you want to observe vessel, please use B8 mode. B8 mode is much sharper compared to A8 mode.
Okay, so B mode is better for visualize the vessel and sharper.
Vessel. Yes, I think so.
Okay. Thank you very much. And if there's no question right now, we can proceed for the next session, and we can gather the question after the next session because it's a very important session. Please lecture us about the role of the IEE for pre-malignant lesions and early gastric cancer detection. I think we will have a lot of questions after this session. Please, Professor Kikuchi.
Thank you very much.